Morning, everyone, and welcome to this webinar. It's Dentistry, but not quite as we know it. My name is James Foster, and I'm Head of Dental Services for Asia and Australasia, and I manage cases within Asia, together with my colleague, Dr. Jim Lafferty, who kindly joins us as well. Jim, like myself, dental legal advisor working in the UK, also manages case for South Africa and also works alongside the UK teams as well. Now, we're delighted to be joined by Chris Howse from Howse Williams, who I'm sure will be known to many of you. Chris was trained in the City of London and admitted as a solicitor in Hong Kong in 1981. In 1985, he set up the medical legal team, which now comprises of 16 lawyers, 3 of who are qualified doctors and a pharmacist. Now, Chris has been representing dentists and dental organisations since 1985 and has conducted cases in front of the Dental Council and defending dentists in the courts for over 30 years. We work very closely with Chris in supporting our members here in Hong Kong and are very grateful for the support that our members do get, because they get extremely well looked after by an exceptional service from Chris and his team. Thank you very much for joining us for this webinar today, Chris.
Thank you.
Now, pre-COVID, I would have been traveling at this time, and the plan for me was to be in Asia. I'm very sorry to have missed the opportunity to meet with some of you again and also to meet new members. This is an incredibly challenging time, and as we can see, whilst we may have periods of low incidence, this virus may pose a threat for a long time to come. I wish you all very much safe and well. Now, members of dental protection around the world have been faced with the same challenges of returning to work and creating a safe environment for everyone. The way we work and the procedures we carry out make the dental practice an almost perfect breeding ground for the spread of the virus, and we're having to face new ethical challenges and legal challenges as we do so. Tonight, we will address many of the key issues and try to answer as many of the questions you submit during the webinar as we can. The dental profession across the world has had to react and adapt very quickly to the pandemic, and the uncertainty attached to the changes we've had to implement has overwhelmed many of us, and that uncertainty has been the driver for the content of this presentation. Now, it's our intention to run the webinar for about 50 minutes and allow some question time at the end. If you have any questions during the presentation, you can send them via the Q&A box, which I hope you can see at the bottom of your screen, and we'll discuss these at the end. Once the webinar is over, you will receive an email asking you to provide some feedback. I'd be grateful if you could complete that. Thank you. So just a reminder of who we are. Dental Protection is the world's leading protection organisation for dentists and dental care professionals. It's a non-profit organisation, it's a mutual fund that is built there for members, by members, and to be used appropriately. Colleagues like Jim and myself are there for responsible management of that fund that is fair to the individual and fair to the membership as a whole. There's much material on PRISM, our material for webinars, for education, CPD, etc. And we find in Asia that not many colleagues use the full membership entitlements that they have. So please, I would urge you all to go look at the website, see what is there, because I think you'll be surprised how much is there and the quality of it. Our philosophy is to support safe practice in dentistry by helping avert problems in the first place, and that's where our educational arm, our risk prevention arm, is so strong. So the key issues we wish to focus on tonight are consent and disclaimers. Consent for treatment, and separately the use of disclaimers as a tool to protect you from a patient who wants to sue you for transmission of the virus. Taking that theme forward, we will discuss the potential threat of litigation and the potential consequences if you're found to have negligently allowed transmission of the virus in your practice. Dental associations in many countries have shown real leadership through the pandemic and overseen the supported the development and publication of professional guidance on clinical protocols. Also, government have determined what steps and actions we should take and should not take, and what are the consequences if these rules are ignored or inadvertently broken. Will we see more claims and dental council matters arising? Claims may take some time to come through, as indeed the dental council matters might as well. Are we going to see an increase? Will we see an increase in low-level complaints? We will also explain the ethical rules supporting the use of teledentistry during the pandemic. And finally, we will discuss some of the key questions around ethical patient management which have arisen in relation to COVID-19. Now, in terms of consent, this slide is just a memory jolt and highlights the three key components of the consent process, commonly called shared decision making. Information. This speaks to the disclosure of relevant information by the clinician, as well as establishing the concerns and preferences of the individual patient. This is a two-way process. Then capacity, the patient's ability to understand the information and to appreciate the consequences of their decision. This is the point in the consent process, where they cognitively process the information and where you check their understanding. And the third point, voluntariness. Patient's right to come to a decision freely, without force, coercion, or manipulation. Now, consent is not a tick or a signature. It's an exchange of information. There is a power and knowledge imbalance in the relationship, and the process of obtaining consent requires you to provide and receive information. Our first job is to listen to the patient. That is active listening without interrupting them, which is not always easy in a busy clinic. Indeed, studies show that clinicians are not necessarily great listeners, although we're great interrupters, and we often want to get on with the doing and the fixing, particularly if the patient is in pain or if we've got other patients backed up around the waiting room. And when we want them to stop talking, we're probably already switched off our listening antenna. This can unwittingly undermine the quality of information sharing and our ability to obtain valid consent. So we know communication is a two-way process, but when you look like you're dressed to handle nuclear waste rather than undertake an examination, things become a bit more challenging. Before we even get to treatment, the first decision a patient will probably make is about attending. Is it safe? You're unlikely to be part of this conversation, but you need to know about it and be alert. Things can go wrong if your team is not properly prepared. If a patient expresses a reluctance to come to the practice for a face-to-face assessment, and where there is clearly enough in the remote history to suggest they should, then the practice must very quickly undertake an assessment of that decision and weigh it up against the potentially adverse consequences of non-attendance. In short, you or your frontline staff perhaps you'll be aware of the possibility that a patient may talk themselves out of attending for treatment that they need. Advice. And on that point, record keeping, the bar is higher at this time, and we need to be recording as against the current guidance that is applicable at that time of seeing the patient. COVID restrictions place an increased responsibility on those carrying out remote triage, and you must make sure your staff have been appropriately trained and are not delegated responsibilities for which they are not qualified. Now, consent is about options and risks. The law requires you to discuss all the usual options and risks for the treatment of patient's condition, whether that treatment is available or not. E.g., you may be unable to undertake a root canal treatment because you've run out of rubber dam. But if you fail to mention this as an option for the patient's pulpitis or periapical periodontitis and offer only an extraction, then unfortunately we will have failed to obtain informed consent for the extraction. So identify the patient's preferred option. Then we have to discuss whether that preferred option is available. The availability of normal treatments may be constrained by levels of restriction or shortages of PPE. And these will vary over time. The status we have at the moment may be very different to that in a month, which would have been different perhaps to 2 months ago. At this point, I also want to mention aerosol generating procedures, AGPs, and how the way information presented about AGPs might inadvertently influence a patient's treatment decision. Until we obtain proper, robust scientific evidence, we are all exercising caution in the provision of AGPs. The restriction of AGPs serves the public interest in lowering the potential for virus transmission, but the risks that the guidelines seek to mitigate are not risks that apply to the patient having an AGP. Arguably then, the increased infection control protocols and PPE do not necessarily protect the patient undergoing the AGP, And it would then be a failure in the consent process if a patient postponed treatment or selected a lower COVID risk treatment to avoid an AGP in the belief that their choice somehow lowered the COVID risk to them personally. We need to be very clear about why we are dressed like nuclear physicists and look completely different from the last time your patients came to see you. It's not normal, and certainly not dentistry as we and our patients know it. You therefore need to separate out the influence of availability, i.e. what treatments can actually be provided that day, and the patient's treatment decision, as this could undermine the voluntariness of the consent process. Now, a signature may be regarded as good practice, but in isolation has limited benefit. The records need to reflect the consent process in that the information has been provided to the patient which they have considered and understood, but essentially it's records, not signatures. How do practices deal with consent forms, and can they be signed online? And as we go through this presentation, various questions will pop up that we've had. So consent is a very wide topic, and it would be a webinar itself. But with regard to a telephone consultation, it would be important to follow the general principles of consent. Inform the patient of your findings, clinical opinion. Inform the patient of the reasonable treatment options in the circumstances, along with the risks and benefits, including the risk of no treatment at all. It may be appropriate in certain circumstances to inform the patient that the only reasonable treatment options at this time are an extraction or no treatment at all. Allow patients time to make a decision and advise them of any potential consequences if the treatment was not carried out. Now, good detailed records of the consent discussion should be made, including what the options were and why, along with an indication that the patient understood and agreed to proceed. In relation to consent forms, apart from areas such as sedation and general anesthetic, there's usually no specific requirement for consent forms to be used. It is important to note that consent forms are not a replacement for the consent process, but may be a helpful adjunct. More important is a contemporaneous, i.e. written at the time of the event, note in the records indicating the consent discussions, as I've previously discussed. Consent forms can be useful in providing additional information for a patient to consider. And you could ask a patient to confirm by email, for example, that they have read the information, but this in itself would not be evidence of the complete consent. As I say, these things are going to change over time, so the level at which we need to talk about with patients on the phone before they come, this may come and change and go as restrictions are lifted or come back. So we just need to be aware and considerate of how we operate and in line with the current guidance, which will change. And obviously we've got a duty to make sure we follow that closely. Now, this may be an Australian slide, but it's actually one I really think is quite helpful, and it's part of a global effort. So a patient asking themselves simple questions. Do I really need this test, treatment, or procedure? What are the risks? Are there simpler, safer options? What if I don't do anything? And what are the costs? So with so many things now in the delivery of, different with the delivery care, it's easy to forget or cut corners in our usual routine. The key message about consent is that COVID hasn't changed anything. In fact, perhaps even push the bar higher up. These are the key questions a patient needs to be able to answer at the decision-making point in the process. And our job is to make sure that they have sufficient information to answer all of these questions satisfactorily. The choosing wisely is a part of a global initiative, as I've mentioned, to improve the conversation between clinician and patient in the consent process, and it gives you a short and useful checklist to fall back on when you need a reminder, and particularly with the elective treatments. I would emphasize the importance. Now, in terms of using a disclaimer, we've been asked about disclaimers by dentists all over the world. The idea of the disclaimer is a means of transferring the risk and responsibility for virus transmission from the dentist to the patient, and somehow giving yourself immunity to a potential prosecution or litigation in the event that a patient claims such an event occurred. However, there are issues to explore here, and might I come across to you, Chris, to expand upon these? Thank you.
The position really with disclaimers follows on logically from consent forms. The purpose, obviously, of a disclaimer is to try and exclude you from any form of liability. But there are a number of problems with that. First, there is no point having a disclaimer form which has been terribly well created and drafted by your lawyers if it is so complicated that the patient doesn't understand it. That's the same with any consent process. So merely because you have a disclaimer which has been well drafted, which purports to exclude you from any liability whatsoever, whatever the circumstances, that is almost certainly not going to be effective. For two reasons. First, the patient will probably say it wasn't explained to them, so they had no idea what you were really trying to exclude. But second, there is legislation in Hong Kong in the Control of Exemption Clauses Ordinance, which is a piece of legislation which specifically says that you cannot rely on disclaimer clauses, exclusion clauses, unless they are reasonable in the circumstances. So what is going to happen if you're in a situation where you are trying to reduce your liability is any form of document, any disclaimer that's been drafted is only going to be effective if it is reasonable. And that takes us on to what is reasonable. What should you as a dentist be doing to look after your patients? Now, there is a very useful source for information for a lot of what I'll be saying this evening in the CHP guidelines, the Center for Health Protection, and you can find a lot of this on the website. And the guidance they give there is really very good indeed. But the sort of things that you want to be considering as a dentist, what reasonable steps should you be taking to protect your patients? The first thing I think to note there is that your duty to protect your patients applies not only when you've got the patient in the chair and you're doing a dental procedure on them, but also in the waiting area, because you have a responsibility for your patient from the time they come into your clinic until the time they leave. So the sort of things you might consider are having sufficient separation in the waiting rooms so that people are not too close together. Following from that, you might consider having a rather stricter system of appointments, so patients are told that they should turn up at the time of their appointment. Don't please turn up half an hour earlier or half an hour later. Another system you could introduce, and this is obviously to avoid contact, so it keeps your patients safer, are using cashless payment systems rather than cash. And one of the ways in which this virus is being transmitted is people exchanging cash, whether it's in taxis, shops, and so on. So the extent to which you can do payments in a cashless transaction is an advantage. Then there are the obvious ones. Obviously, you should have hand sanitizers available in your clinic. Almost every shop, every hotel, every office in Hong Kong has hand sanitizer freely available. I'm sure all your clinics have that as well. You might also consider having spare face masks. There's always going to be a patient who turns up who's forgotten or lost their face mask, even though they should have had it when they were on out in public. It might be wise to have a stock of spare face masks that you could provide to a patient, because you can't have patients in the public area of your clinic, in the waiting room, unless they're wearing face masks. Another thing you might consider is whether your staff should have regular COVID tests. Now, that's partly to reassure your patients, but it's also to look after your staff, which is equally important. And as I'm sure you all know, in Hong Kong, you can get COVID tests very quickly indeed in the private sector. And I would have thought that is something that is worth considering. Going on to slightly more dramatic solutions, if you are short of PPE, if you do not have adequate PPE, I think the correct procedure would be to close your clinic. And I have known some dentists that we've been discussing these issues within Hong Kong have decided that when the case is escalated to a very high level, they were simply going to close their clinic anyway, because they did not want patients put at risk, and they did not want their staff put at risk because of the increased dangers from COVID, because of the proximity in which you're working in a dental setting. So moving on from there, the other thing I think I would stress is it's important, as James said, that the COVID-19 risk and the increased risk that a patient has when they come to see you should be something which you mention as part of the consent process. So when you're going through the treatment, whatever that treatment is, whether it's RCT or a crown or whatever, I would strongly recommend that as part of that process, you explain to the patient that there is an increased risk, despite all the precautions you've taken, and the patient must understand that there is that risk. And if the patient is at all unhappy, I would think the correct course of action is to say to the patient, if you would prefer to defer this treatment, it's not urgent, it's not going to make any difference if you come back in a month or 2 months, then you should certainly consider doing that. So give the patient the option, and then please, the final but one of the most important points, please make a note in your patient notes that you've gone through that advice, so you can protect yourself in due course. If you want to look at the detail of recommendations to how to keep your clinic clean, the CHB guidelines, again, there's an entire page on what is recommended in one of 3 circulars that they've sent out. If anyone's interested in these letters, I can arrange them to be forwarded afterwards. But they really are very helpful indeed in giving guidance to you as practicing dentists on how to keep the clinics clean and what procedures to follow. Can we go to the next slide then, James? The next question I was going to answer briefly in this section is, can a dentist be sued if a patient contracts COVID-19 in his clinic? The answer obviously is yes. There is nothing to stop you being sued or you having a complaint made against you to the Dental Council. If you are faced with either a complaint or a claim, we are going to be looking after you with DPL, and what we will be doing is showing that you took all reasonable steps, and the basis of that is undoubtedly going to be everything that's in the CHB guidelines. You want to be able to show you took every possible step to look after your patient, and that you cannot be criticized for being what lawyers would call negligence, what the Dental Council would call having treatment which fell below an acceptable standard because you did not look after your patient. It's very difficult to give specific answers to would a claim against you be successful, because nearly all these claims are fact specific. And in Hong Kong to date, there has only been one case that we're aware of, which was a claim against a hospital for not providing a safe system within a ward when they put a COVID patient close to other patients. And we don't know the outcome of that yet. But there are a series of cases which date from 2003, 2004 to do with SARS, which are cases involving either a member of the hospital staff contracting SARS and making a claim against the hospital for an unsafe place of work, alternatively a patient making similar claims. Interestingly, none of those cases have come to judgments, which suggests that they were settled before they came to a court decision. But the test will be the same. Have you provided a safe system of practice? James, I think it's back to you for
thanks.
The next slide of who protects you.
Yeah, thank you, Chris. And interesting, we are aware of some a couple of medical cases where patients are challenging in relation to contracting COVID-19 in other countries, and it'll be interesting to see how much this raises its head. But in terms of protecting members, there's a quick summary there. I'll just take you through this really is perhaps the most second common question we've been asked, is whether we would provide an indemnity if a patient actually attempted to sue for transmission where guidance had not been followed. The first thing I need to make clear is that COVID-19 has not placed any restrictions on the scope of indemnity, and your right to request assistance is unaffected. The access to indemnity does not provide immunity in the event of a patient sues, however, or reports you to the HKDC. So we've had some situations where people have said, oh, if I'm indemnified, I'm protected, I'm covered. If you don't follow the guidance, you're exposed and vulnerable to a challenge from either patients or the Hong Kong Dental Council, or a complaint from a patient. Indemnity doesn't prevent, which is just a point I need to get across, because people were asking about indemnity, and if they've got indemnity, then they're covered, perhaps their guard goes down. Please consider it essential to maintain your standards to protect your professional reputation. The indemnity does not itself provide the protection, it's support for you should there be a challenge. So look at these three scenarios. If transmission takes place in the room, then dental protection would look to assist, and that would be based on a claim of negligence that the cross-infection controls had not been followed. So in case one, the dentist is providing care that's followed guidance and correct use of PPE, had also implemented social distancing protocols, and had used remote channels for communication to identify and isolate patients at risk. So in terms of point one, then we will be there to assist. The second scenario is completely different, where a dentist deliberately chose not to follow the guidance and failed to use PPE, putting themselves, their staff and their patients and the wider population at risk of transmission. Such behavior may well be considered deliberately reckless and irresponsible, and would normally invalidate the terms of any insurance policy. If such a situation arose with a dental protection member, then whilst being indefensible legally, it would also raise questions about the level of support a member should receive from dental protection as it amounts to the individual's personal conduct. HK Dental Council would be deeply concerned if their investigation of a complaint alleged poor compliance, and the issue of safety is the top of every agenda, and there will be little tolerance of compliance failures. So please, in terms of following the guidance, we would emphasize the need to be scrupulous in doing so. If the transmission takes place in the practice but outside the treatment room, then that's perhaps where your public liability insurance should be approached and should be implemented. And if a member of staff contracts COVID through a failure to implement the necessary safety measures, then perhaps that would fall to employer's liability. So we're looking really at the situation within the surgery where there's a claim of negligence in regard to cross-infection control. And of course, please do approach us if you are in the unfortunate position of being challenged in that way. So what about our own infection status, and that indeed of our staff? Now, you've touched on it, Chris, and I wonder if we might come back to you to just go and explore that a little bit further.
Certainly. If we go, I've entitled this slide COVID-19 in the clinic, and I've asked what I'm sure are the obvious questions. The answers to all these questions you'll find again in the Centre for Health Protection website. And the requirements are strict, and they are backed up by the force of law. So first, what should you do if there is a COVID-19 case in your clinic? First, you need to close your practice immediately, and you need to tell your staff to stay at home until further notice. Second, as the clinic owner, you must arrange for the premises and equipment to be thoroughly disinfected as soon as possible. Third, you are required to provide the Centre of Health Protection with a list of staff who've worked in the practice during the previous 2 weeks. The list should include name, identity card number, contact telephone number. Fourth, the practice remains closed until the Centre for Health Protection advises otherwise, and this may be a few days, depending on how quickly the Centre for Health Protection can identify all close contacts. So there may be a delay before the CHP will even tell you when you may be able to reopen. It is likely to be some time. Fifth, your practice will be listed as sitting in an infected building in the press. And as I'm sure you're all aware, there is a government website which identifies every building in Hong Kong where there have been cases. So that's the first part of what you have to do. The next section is what will the CHP, the Centre for Health Protection, require. First, as I've said, they will require you to identify all staff. They will then ask you to identify all patients who are close contacts of the staff or who've been in your clinic. All those people will be tested. They will be sent to hospital if positive. They will be sent to government quarantine for 2 weeks if the first test is negative. And as you know, there are then repeat test procedures. The CHP has the discretion to decide who are close contacts, and they will look at whether there is any face-to-face contact without protective equipment or surgical masks, and if the staff ate together, etc. That means that if you had 2 members of staff and they were not both wearing masks, they are in close contact. If you have staff who eat lunch together, you should discourage this, regardless of whether you have a case in your clinic or not, because that is also amounts to close contact. But what will happen in this situation is the CHP will want a list of absolutely everyone who could have been in contact within a 14-day period up to the time when the case is found. Now, given the nature of your practice, it is probable that CHP will want a list of all patients who visited the practice in the last 2 weeks. They'll want to see your appointment records. They'll want to see your treatment details. Patients will be treated exactly the same way as staff. They will be sent to hospital if positive. They'll be quarantined for 14 days if it's negative. And as the COVID-19 is classed as a public health emergency, the usual rules regarding data protection do not apply. You are required to hand over this information. So it is an exception under the usual data protection legislation and your duty of confidentiality to your patient. You must hand over all this information to the CHP to enable them to contact everyone. When can you return to work? When can members of your staff return to work? The short answer is when the CHP says that they can and not before. So that, I think, deals with the situation as to what happens if you're unfortunate enough to have a case in your clinic. If we can go on to the next slide, Jane. Next slide.
Yeah, sorry, coming.
I hope, there we go.
There we go.
This is worth looking at quite carefully. What is your exposure if you don't follow the rules? And the consequences, I'm afraid, are quite serious. First, we mentioned briefly, if you have a problem in your clinic, if you have you've exposed patients to COVID-19 in your clinic, there is potentially a civil claim against you for financial compensation by the patient. Now, what the patient is going to have to show is that you were negligent, that the systems you had in place were not good enough, and that put the patient at risk. Similarly, if there is a complaint by a patient to the Dental Council, it's going to be the same exercise. Instead of negligence, it will be stated that you had, or alleged that you had systems which fell below an acceptable standard, and as a result of those substandard systems, you've exposed your patients to risk, they've caught COVID-19, and as a result, you will be found guilty, I have no doubt, by the Dental Council. The next one, civil claim by an employee. Now, I'm not sure whether this would fall under the scope of DPL cover, but as an employer, you have a legal duty in Hong Kong, as I'm sure you all know, to provide a safe place of work. And if you do not provide a safe place of work, the obvious example would be sufficient PPE equipment or insufficient sanitizing of equipment or sanitizing of door handles, shelves, anything that patients come into contact. That would be an unsafe place of work, and that will expose you to a claim by your employee. In all those three categories, I have no doubt at all that everyone will look at the CHP guidelines, which set out quite clearly what you should do. And if you haven't done that, I think you would have a liability. If you fail to report a case of COVID-19 is a reportable infection in Hong Kong. And if you do not report a case of someone who comes to your clinic or an employee, you have a potential liability under the Prevention and Control of Disease Ordinance for any failure to report. Finally, and perhaps most serious, you could be exposed to criminal proceedings if you, as a dentist, know you have COVID-19 and you continue to treat patients. That's under Section 32 of the Prevention and Control of Disease Ordinance, but that is criminal. So that is proceedings brought by the government, by the police against you with criminal sanctions thereafter. I am not aware of any case in this at the moment. James, back to you, I think.
Great, thank you. And then, of course, you've got the follow-up with the Dental Council, which is where we'd be involved with the criminal element, in that we'd be assisting at the Dental Council. And I think for the employee situation, employment liability, employment law is a separate issue to the indemnity, but certainly there to help when it's relevant for us. And we obviously do stress, and thank you, Chris, for your comprehensive answers there. You do stress the importance and the vulnerability at such a heightened time as well. I mean, there's a very emotive approach from regulators and authorities at the moment if you are not following the guidance set out clearly. I mean, it's quite an aggressive response you will see from those in charge. In effect, you know, this is such a serious issue that those people blatantly not following are really running risk of the book being thrown at them. That's the term I'm looking at.
I mean, James, is very similar to the SARS cases. There are, to my knowledge, very few SARS cases that went to a judgment. I'm quite sure if we had a DPL case where there's either a claim by a patient or there's a complaint to the Dental Council, I'm quite sure that any civil claim by the patient, you quickly establish whether or not we are up to standard or not. If we're not, we settle it.
Yeah.
If it's Dental Council, you obviously can't settle it, but you would accept liability. You'd accept you fall below an acceptable standard, and that would be the end of it.
Yeah, just that I was thinking perhaps in terms of the reputational damage to a practice and a practitioner if they were publicly known to have flouted the laws. You know, any reckless behaviour, it's very significant, and it's going to be well publicised.
Yes, no, it would not be good, and the newspapers would definitely jump on it straight away. Yeah,
we're seeing that in other countries. They really are going to town. So that's great. Thank you very much. If I might come across to Jim for this interesting question, you know, will we see an upsurge in dental legal claims?
Good evening, everyone. Well, first of all, I think the quick answer is we don't yet know. So it's a really interesting question. And we need to take into account kind of the extraordinary and unprecedented situation our dental profession's facing. So it is a bit difficult to predict what the impact is going to be on claims experience. But if you think about it logically, there's quite a period of time where many of us are only undertaking a fraction of our normal clinical work. And therefore, the risks that arise from actual normal treatment and higher risk procedures will be significantly reduced. What we might see though is an increase in complaints and cases that arise where patients believe they weren't given correct advice, or they didn't get an appropriate referral for emergency treatment when they felt it was needed. So in order to protect yourself in this kind of environment, it's really important that you make sure your patients receive clear information about how to seek emergency care and advice, particularly if it isn't from you and their normal clinic. You should clearly record details of all contacts with the patient, including full details of the assessment you've made, the diagnosis you've provided, and probably most importantly, the advice you've given them. The advice you give them should be consistent with current guidance. And we also know that emergency treatment can carry a different set of risks, particularly if you're treating patients you don't know and you don't have their historic records. So we're anticipating some claims arising from this environment. If you then look at the bigger picture, we've got an economic downturn that's associated with the pandemic, and we have previously seen an increase in claims. So we might get a rebound in the number of claims in the longer term due to the financial impact the pandemic has had on the economy. So one potential risk area might well be from patients who end up requiring emergency treatment in a referral centre and who then question whether the need for that treatment could have been avoided. So we are keeping a close eye, we're constantly reviewing our data to look at the impact and to share our insights. And naturally, if you receive any challenge from a patient in any of these areas, then our advisory team will be happy to provide the necessary support to you. Can we have the next slide, please, James?
There you go.
Thank you. So there is a risk from the patient group who are unable to access care, who have had treatment during the lockdown without access to the full range of services that are normally available, and who might, for example, not have been contemplating an extraction when they're presented with an emergency. But there are a number of steps you can take to reduce that risk. So as many of you will already be aware, in order to be successful in bringing a claim in negligence, a patient must first show that the defendant owed them a duty of care, and that the defendant breached that duty of care, and that the claimant had suffered quantifiable harm as a result of what we call causation in dentolegal terms. So if we look at each of those three components of a claim in turn, so the duty of care is pretty obvious in the dental arena. So if you've offered treatment or advice on a face-to-face basis, or you've prescribed antibiotics or analgesics, then you've got a duty of care to that patient. But you can also establish a duty of care if you've triaged a patient, and even if that only resulted in verbal advice being given. So when we discuss a breach of duty, the fundamental principle is that the onus of proof is on the patient to show that the care provided the practitioner fell below a reasonable standard. So the basic standard is that of the reasonable person in the circumstances of the practitioner, and it's very important to emphasize the circumstances, the word circumstances here. So in other words, a professional person must meet the standard of competence of the reasonable professional doing his or her job. So the COVID-19 situations led to the introduction of guidelines that have severely limited the way in which we can work and the range of treatment options that are available. It's had a significant bearing on what would be considered reasonable in the circumstances. And a course of action that might have been reasonable in pre-COVID may not be reasonable under the restrictions, or it might even be impossible. So it seems unlikely that you'd be found in breach of your care of duty if you are following national guidance. I think handing back to you again, James.
If I might just take you forward there, Jim, to now approach the risks in teledentistry, which is an area obviously that has been rapidly thrown to the fore, as indeed telemedicine has as a result. Thanks, Jim.
It has. So the number of kind of channels that we communicate with patients has increased during COVID. So the opportunity for non-face-to-face communications, and it's a really good way of undertaking a COVID assessment and following up on outcomes with individual particularly vulnerable patients. But there are risks with that, and both us and patients might push the boundaries and cut corners where a diagnosis and treatment plan really ought to have had a face-to-face assessment. So the duty of care begins the moment you provide that assessment and provide advice online. There are risks associated to remote prescribing of medications, especially if you don't know the patient and you haven't got access to their previous records. And there's obvious things around anaphylaxis associated with the penicillin family of medicines. I kind of then move on to record keeping and how we process and store data. What are you going to do if your patient sends you a photograph of their mouth? If they send it to your personal mobile phone, are you going to delete it, or are you going to save it? Is it part of your record? And the other kind of wider issue, particularly in smaller countries, is international boundaries. Are you giving advice to somebody in Hong Kong? What happens if they're not registered in your country? So there's clearly going to be some big changes in the way we interact with our patients, particularly when we're doing that remotely. But right now there are some significant challenges and probably not enough solutions.
If I might just add, Jim, in terms of the indemnity, the provision of indemnity that we've taken is that if you are advising patients, then that's absolutely fine. But if it's a new patient you've not seen before and they're in a different country in which you're not registered, that's not something that we would feel comfortable with. So we wouldn't be in a position to indemnify in that circumstance, but we would in others. Okay, again, please, we'd ask people to approach us in that circumstance.
Indeed. I wondered whether we could bring in Chris here, because in medicine, remote consultations are even used far more. So have you got any experience yet, Chris?
Yes, well, you could probably do a separate webinar on this. We've had
Yes.
a whole range of interesting questions. Obviously, first, doing teledentistry, it has not changed. So if you're doing anything over a telephone or a Zoom or a video conference, whatever it is, you must satisfy yourself that you've got enough information to be able to treat. And that in dentistry, I imagine at times would be very difficult because you can't do intraoral examinations. But that's the basics. The two most recent, I mean, we've given lots of advice to people who are giving information remotely. Three very quick things we've had. First, can you give drugs to medication to someone if they don't attend in your clinic personally? Can you give it to a friend of the family or someone who turns up with a letter? The answer in Hong Kong is yes, you can, but obviously you need to check that it's a patient you know and that it's a medication that they should be taking. The second point which has come up is, can you send medication out of Hong Kong to another jurisdiction? The answer to that is no, not without the appropriate license. And I suspect it would be too much time and trouble to get a license. The answer almost certainly is to tell the patient to see someone in the jurisdiction in which they are. If they needed background information, then the correct course of action would be the patient identifies a dentist wherever they are. Let's assume it's a Hong Kong person, they're in New Zealand. Right, go and see a dentist in New Zealand. Get that dentist to contact the dentist in Hong Kong with the patient's consent, and get the patient notes, and off you go. And that's, we think, the better way to treat. The other one, which some of your members, some of the people on this webinar may have come across, is we had 2 or 3 days ago, we had a dentist who phoned up and said, I've got a real problem. I've got a patient in reception who is refusing to remove his mask so that I can identify him by reference to his ID card. And we're concerned about this because we think we've had people coming into our clinic to collect medication when they aren't the person they say they are. Can I make this gentleman remove his mask? Because when he was asked to do so, he promptly said that was a breach of our legislation to expose his face without a mask in public. There's a debatable point as to whether a dentist clinic is in the public area or not. Unfortunately, we don't need to look at that, because in our legislation there is a specific exemption which says that where you need to temporarily look at someone's face to identify them, that is permissible, and that's not a breach of anything. So
Right.
that was the most recent interesting question that came up.
Well, it's an interesting area. Certainly, general practice, general medical practice, is going to change completely in many countries, and obviously in dentistry, it's going to be significant changes, but obviously nothing like the same extent. But we need to be aware of what the legislation is at the time, what the restrictions are, because things will vary, whether we're making more phone calls or less. There may be fluctuations in how much of that we do going forward. Jim, might I come back to you then on treating our patients ethically and fairly?
Yeah, so we've found ourselves facing some very challenging ethical scenarios. In many ways, it's a bit like a Rubik's Cube. So the ethical issues are the faces of the Rubik's Cube, where the faces can be twisted and turned to show different ethical configurations. I've got an 11-year-old boy who's just got his first Rubik's Cube, and trying to put across to him that every time you move one face, you have an impact on 3 more. And I suppose there are parallels in dentolegal circles. It's the interplay between your communication, consent, clinical treatment, and your ethics, so that they all affect each other. Each day and each patient brings a unique combination of those ethical issues. And that kind of represents the risk exposure at that particular time. It has been said that our wisdom is all mixed up. Well, so is our risk during the pandemic. May I have the next slide, please, James? Thank you. So, with the inevitable changes to the way in which we are delivering patient care, how can we manage our patients' expectations? So we all know things are very different now. There's new ways of working, and those are meaning considerable changes for how our patients access care, how we try and prevent infection, and infection control is very different. Social distancing and patient flow through the practice, remote consultations, remote triage, they're all large parts of our patient care. It's really important that we manage the patient's expectations and prepare them for those changes that have been implemented for their safety. So that patient experience is going to be completely different. Remote consultations continue to be part of the patient journey. And it provides you with a great opportunity to manage patient expectations from the outset. So there are various ways in which you can manage those patient expectations and help maintain confidence in the profession at this time. So communication is going to be key. And I know a lot of practices have put together letters advising their patients that it's unlikely to be business as usual for some considerable time yet. You can include, if you send those letters, what measures have been put in place for patient safety and what to expect when they attend for an appointment. And so, as Chris alluded to earlier, this may include waiting outside the practice until they're called in, answering some screening questions about their COVID status and the potential for asking about their symptoms, and having their temperature taken on arrival, directing them to use hand gel, and not attending the practice without an appointment, attending alone. Obviously, there will be some exceptions to that if you're treating children or patients who need a carer. One thing we've seen quite a lot of in the UK is a video tour posted on the practice websites, which demonstrates the patient journey. And I know my own staff have been filming one of those this week and are currently editing it so that we can put it on our own website. And that really helps ease anxiety for patients, so they've got a much better understanding of what to expect. We've also put on some photos of what we look like in all our PPE, and we've been using social media to tell our patients what the protocols are, and that we've got lots of new signage. So that we've got signs on the front door, on the window of the practice, and inside the practice. And those help direct our patients through various stages of that patient journey. One of the particular ethical questions we have, can we go on to the next slide, James? Thank you. And that we've been receiving a few queries about is whether you can refuse to see a patient who's shedding virus, but they've got a dental emergency on the grounds of your own safety. So if you've got a patient in urgent need of dental treatment, you should refer to any nearby government hospital. So yes, you can refuse to see them, but you've got to provide some form of referral for them. So can I bring in Chris to answer about the lack of PPE as a reason not to see patients who've got emergencies?
Certainly. I mean, the short answer is if you do not have sufficient PPE in your clinic, I think you would be unwise to be treating a patient. Firstly, because you're putting your staff at risk. Second, you're potentially putting yourself at risk. And if the patient were to have the virus, I think you're exposing yourself and your staff to an unnecessary risk. If it is routine dentistry, again, going back to my favorite subject, the CHP website, you will find that if there is a direction there in their circular letters that if anyone is showing any symptoms of COVID-19, you should not be treating them unless it is an emergency. So if it's routine dentistry, put it off. I would say do not treat. If it's an emergency and you don't have PPE equipment, I would send the patient with a referral letter, as Jim says, to A&E in one of our hospitals and get them sorted out because they will be equipped.
I think it's interesting that because I think MPS has taken a position overall, be very supportive of healthcare workers, our members in those circumstances to support the fact if you haven't got the PPE, you need to look after yourself, and I'll come more to that on. So Chris, moving forward, could we just ask your opinion in terms of if a patient is requiring emergency treatment and has no wish to tell the dentist because they're in so much pain and they want treatment?
I can deal with that one very briefly. Can I just pick up on what you were just saying, James? One,
of course, yeah.
about the risk that a dentist is required to assume. There have been circulars, which I'm sure you've seen from WHO, which says that the duty of a doctor or a dentist to provide treatment is not unlimited and there's no imposition on them to provide treatment without taking into account the risk that they're taking. So even the WHO seems to recognize that there will be circumstances in which it is reasonable to refuse treatment, whereas previously you might not have done.
Yeah, indeed.
Moving on to this slide, this is very straightforward. Can a dentist sue a patient if they attend his clinic and they don't inform the clinic that they have COVID-19? So we've got a patient who knows that they have COVID-19. The first point to make there is that is a criminal offence, and the patient would be liable to criminal proceedings under the Prevention and Control of Disease Ordinance, Section 32, for exposing other people to a virus he knew he had. Could the dentist bring a legal action? In my view, the answer is yes, because the patient is acting recklessly and irresponsibly by turning up in the clinic for treatment, knowing that they have the virus. Your problems with any such action are likely to be proving things, because I feel it's unlikely that a patient is going to admit that they had COVID-19. They're going to deny it, in which case can we then show that they should have known, and so on, and you're back to previous topics. But in theory, there is no reason I can see why you should not bring a civil claim against the patient who has come to your clinic knowing that they have the virus because they're exposing you to risk.
I guess the litigation process is also quite a acrimonious one, and it may be a journey that if someone was considering taking, it needs careful consideration, because at the end of it, so many people look back after litigation and regret the process, patients as well as medical staff, don't they?
Well, I think if you, yes, I agree, James. I mean, if you were the dentist in this situation, once you've got over your annoyance that you've been put at risk, I think the first thing you would have to look at is what financial loss you've suffered.
Yeah. Yeah.
Now, going back a few slides, the first thing that our dentist has got to do is notify the CHB.
Yeah.
So the first thing that's going to happen is his clinic's going to be shut down, then he's got to get it deep cleaned, then he's got to identify everyone who's been clinic and staff in the clinic for the previous 14 days. There's definitely going to be a loss of income here.
Yeah, yeah, no, that's true.
So it is, I think, there is a real possibility of being able to pursue a successful claim if someone does this deliberately.
Yeah.
Where I think you'll have difficulty is I bet the patient won't admit that they knew.
Yeah, yeah. So with caution. Okay, Jim, if I could come back to you, this is taking the working without PPE session or issue just a little bit further to involve the individuals within the practice.
Yeah, so we've had, in fact, pretty much in every country in the world where we provide membership, we've had members who have phoned or emailed in saying they're concerned that they're being asked to work without appropriate PPE and what should they do. In the UK, we've had quite a few hygienists and therapists asking that question. So you should be using the correct PPE for the particular clinical procedure you intend to provide or will be involved in. And that's obviously got two purposes. Clearly, you're going to be concerned to protect yourself from any risk of contracting COVID-19. And in protecting yourself, you're protecting your patients from potential onward transmission of the virus. So this should be taken into account in your practice's standard operating procedures. And the guidance in all countries is very clear. You must use the appropriate PPE. It should be properly fitted, and you should be trained in its use as well. Whilst I can appreciate it's not easy to express your concerns in these situations, where you are challenging an employer, there is the potential that your employment can be put at risk. It may be that your practice, like many at the moment, is struggling to get hold of enough PPE. So in the first place, you should check that your understanding of the correct level of PPE for each clinical circumstances. So are there other ways of making sure this patient can get the care they need? Like Chris has said a couple of times, can treatment be delayed, or can the patient be referred onto a designated centre? If it isn't possible for you to manage the situation satisfactorily, you should let your practice owner or the employer know you can't undertake the treatment until appropriate PPE is available. If you continue regardless, you would, in any case, you put yourself at risk of challenge. And even if you are indemnified to carry out the planned treatment, even with dental protection standing by your side, it might not be possible to defend your actions. Regulators such as HKDC are likely to accept that refusing to treat a patient when you consider it's not safe to do so is a matter of professional judgment, and it seems to be unlikely you would be challenged in this regard.
Thanks, Jim. Now, just in terms of bringing to a close, I'm aware we've run a little bit over, forgive us for that, but if I might draw to an end, when faced with the ethical dilemma that we're seeing, we sometimes can make poor choices on the spur of the moment, and afterwards we'll try to justify what we did, a form of situation ethics, and we must guard against that. Never before have we been faced with ethical decision making that could potentially lead to the death of a patient if we get their management wrong, or even our own and loss of our business. Ethical decision making during the pandemic has such serious consequences, and no more is it only the patient's best interests that are paramount. Right now, all of us need to focus on self-preservation as well. Self-sacrifice is perhaps the stuff of dramas and stirring epic films. Self-sacrifice is not the stuff of frontline healthcare, and most of us joined the healthcare profession not to risk our own life, but to save others. guidance is there not as a punishment, it's there for safety and self-protection. And never before has risk management meant so much, and never before has our ethical decision-making had to take into account so many variables. It's dentistry, but definitely not as we know it. And that brings the presentation to a close. Now, I am aware that we've run over, but we do, I think, I'd like to stick in one question, if I may, and I'll throw that open to my colleagues in tonight's presentation. I just wonder if we have enough scientific evidence to close clinic and not providing dental service to our patients because the risk of COVID-19 is outweighed the benefits of our dental treatment for the benefit of oral care. So, question about perhaps the interpretation and the guidance that we've had. Gentlemen, would anyone like to comment on that question? Now, my own view is if we're looking to challenge the scientific evidence, how would that be? Where have we seen that in other countries? We've been through that process elsewhere, Jim.
Yes, so that there are different ways of interpreting the evidence and research that's out there, but the biggest problem is the lack of that research and evidence and the specificity of it. So although we know an awful lot about dental aerosols and how far they spread over what time, and the size of droplets at different distances, what we don't know is what that does to things like the COVID aerosol. You know, we don't know whether it's diluting it, whether it's reducing viral load. We really don't know enough. And there are very, very few dentists who have the scientific skills, knowledge, experience to interpret that data accurately. And therefore, we would then fall back on that guidance. And that will be the standard against which you're going to be tested in the event of either a claim or if it went in front of the regulator. So if you are going against that guidance, then first of all, you would need to have a very, very good reason for it. And secondly, I would strongly encourage you to ensure that your records reflect why you chose not to go against that guidance.
Yeah.
And so if the guidance, if lockdown is increasing in the area you're working in, and you're advised to close, then you would be rather unwise to remain open.
Yeah, I think it's going against the guidance should only be for the most exceptional of circumstances. I'm sure Chris would agree.
In Hong Kong, you would be required to close. The CHP would have control of the situation.
Yeah.
I know some. I mean, it's a very difficult time for dentists in Hong Kong. I'm obviously dealing with dentists on a daily basis. I don't know anyone who shut their clinic. I certainly know people who say that their number of patients is significantly down, but provided you are careful and provided the patient knows the risks and is advised of the risks and you're running your clinic properly, I don't see one shouldn't continue to practice as a dentist. And indeed, I'm going to see my own dentist tomorrow.
Right, and I wonder if part of the question was having to close when one of your staff or a patient has had it, the implementation of restrictions, you have to shut down. And I guess the question may have been, is there enough evidence to support that? But of course, at the minute, we have to follow the guidance because others are providing that guidance, and we need to follow that.
Yes, and certainly in Hong Kong, there's not an option. You have to follow the regulations, or you are in serious trouble.
And at the present time, we've got to wait for further confirmation as the science improves or the science research has.
We've already had it arise in our practice, James, where one of our nurses had dinner out with a friend who 5 days later tested positive. So we then had to ask her to self-isolate for 10 days. So she didn't come into the practice, and then obviously rejigging the rotas and who was working where. But you can only work out what you're doing by reference to the local guidelines.
Guidance, so, yeah, indeed. And as we've mentioned during the presentation, that may well vary from time to time. These things are going to change, and we've sort of tried to cover all potential elements, but you've just got to be aligned to the guidance at the exact current time. Gentlemen, thank you ever so much. We've run over. My apologies to our colleagues who are watching, but I do hope that there's been some helpful information there. Chris, thank you very much indeed for your comprehensive answers. That's been most helpful. Jim, as ever, thank you very much for your help and support. We just sign off by saying we appreciate it is a very difficult time for dentistry in Hong Kong. We're there here to support and help. Please get in touch with us if we can be of assistance, and we all wish you safe and well. Good evening and thank you.
Good night.